My name is Swanstrom. I'm at the IHU Strasbourg here in Strasbourg, France. And on behalf of my co-writer, co-author, Nathan Conway, I'd like to thank the editors of Gastrointestinal Endoscopy for allowing us to comment on a recent paper entitled Endolumenal Suturing, a new endolumenal flexible endoscopic suturing for minimally invasive therapies. This was a review paper that analyzed the current literature looking at this new modality. Suturing is a core principle of surgery, and since it's been applied over the last few years to flexible endoscopy, it's opened a new horizon for new minimally invasive therapies using the flexible endoscope. We looked at the literature to date that described this and found that there's indeed a great deal of literature that supports the use of flexible endoscopic suturing as a new modality to perform a variety of procedures. We found out of 1,350 articles, 141 articles that were suitable for inclusion in a review. These covered 3,049 procedures. We were impressed by the sheer number of procedures that were in the literature for what's relatively a new advance in surgery. 64 of these reports covered endolumenal suturing in humans, and this goes back all the way to 2004. In fact, it should be noted that the first recorded use of endolumenal suturing was in 1999, establishing a long history of this, which is something that today we think of as relatively recent. While there's a variety of technologies that were described throughout this report, the most recent technology uses true endolumenal suturing with a on-the-scope type of device that passes an actual suture, either absorbable or non-absorbable, through the tissue and allows the endoscopist to suture it down tight. This is described in closing fistulas, perforations, and intentional incisions in procedures such as notes. We're going to show a brief demonstration of this current technology, which was the most widely used with 86 citations in our report.
Hello everybody, my name is Peter Havax, and with my colleague András Legner, we are happy to introduce you the Apollo Overstitch suturing system. The system consists of a suturing device, a 2-0 absorbable or non-absorbable thread, a needle loader, a helical tissue retractor, and a cinching device to seal the thread. The device can be installed on a double-channel therapeutic Olympus gastroscope. The suturing handle can be installed just at the level of the working channels, and the tip-mounted device easily fits in the bigger working channel of the scope. After the device is installed, the needle loader should be loaded. The needle is loaded in the working channel that will press the tag needle to the articulating jaw. Once the needle arrives at the tip, the jaw should be closed and the needle should be loaded in the articulated jaw. If needed, a special tissue retractor helical device can be introduced in the accessory channel. Once the scope will advance to the tissue, after the right deepness of the bite, the suturing can be started. When the needle is logged, the suture passer is introduced and taking the needle from the jaw to the suture passer. After that movement, the jaw can be opened, the tissue should be pushed away from the tissue, and the needle can be reloaded in the patient, make it unnecessary to remove the scope from the patient. And the suturing can be continued. The suture cycle can be repeated as many times as it's needed to complete the suture. Once the suturing is finished, the tag needle is released. Tension should be applied on the needle, and the suture loader should be changed to a cinching device.
The assistant is responsible to lead the suture through the cinching device. There is a dedicated loader preloaded. Once the suture was passed, the loader is pulled and the suture goes in the proper place. Gentle tension is applied on the thread for easy load of the cinching device. Cinching device is advanced until rests on the tissue. Then, by putting tension on the suture, the cinch is fired until it cuts the thread and leaves the cinch. Complete suture comprises 2 T-fasteners on either side.
One criticism we point out in our review was that the quality of literature overall was not high. These were mostly small reports, many of them from animal studies, and very few were high-level comparative studies. Hopefully this problem will be resolved in the future with randomized, prospective, well-constructed, scientifically validating studies. In the meantime, though, what we can say is that there's a huge volume of procedures being done using new endoluminal suturing technologies. This approach has opened a door to a new type of surgery that's truly surgical endoscopy and truly minimally invasive. We think that this is going to be a way of treatment of future diseases such as early cancers and others, and hopefully we'll see many more advances in the technology and many more documents of their use in humans. Thank you once again for allowing us to comment on our paper, and we appreciate the opportunity.